a lot. That's why it makes sounds, you know.
Okay, okay.
Okay.
So, as a continuation for the second part of lectures, the 2008 guidelines for management of adult congenital heart disease, the American Heart Association guidelines. So we will go through the topics that we mentioned in the adult congenital. So starting with the recommendation for the interventional and the surgical therapies for the ASD. So I'm mentioning each disease. I'll mention just the recommendation and the class of each. So for ASD, class 1 was that the closure of ASD either percutaneously or surgically is indicated with the right atrial and right ventricle enlargement or without, even without symptoms, with or without symptoms. That was level P evidence. The second, a sinus venosus, coronary sinus, or primum ASD should be repaired surgically rather than by percutaneous closure. This is class B evidence. Third, the surgeon with the training and expertise in congenital heart disease should perform operations to various ASD closure. This is a class C. As we mentioned in the previous study, that the surgeon with the congenital heart disease are more reliable, or they have much expertise dealing with adult congenital rather than the adult acquired heart disease. So the class 2A, first, the surgical closure of secondary ASD is reasonable when concomitant surgical repair, replacement of tricuspid valve is considered, or when the anatomy to the defect precluded with the use of percutaneous device. This is the level C evidence. Second, of class 2A, a closure of an ASD, either percutaneously or surgically, is reasonable in the presence of one of two, paradoxical embolism, this is class C, or documented orthodontia platypnea. This is level B. Class 2B, number one, the closure of an ASD, either percutaneously or surgically, may be considered in the presence of net left to right shunting, pulmonary artery pressure less than the 2/3 of the systemic, or pulmonary vein return less than the 2/3 of systemic vascular resistance, or when responsive to either pulmonary vasodilator therapy or test occlusion of the defect. Patients should be treated in the conjunction with the provider who have expertise in the management of pulmonary hypertension syndrome. This is level C. Secondly, of class 2B, concomitant MACE procedure may be considered in intermittent or chronic atrial tachyarrhythmias in adult with ASDs. This is level C. Class 3, patient with the severe irreversible pulmonary artery hypertension and no evidence of an left to right shunt should not undergo ASD closure. This is level B. Indication for closure of ASD should include a small ASD with the diameter less than 5 millimeter, uh, no evidence of RV volume overload, may not require closure, as we mentioned previously during that first lecture. They may even close eventually by themselves. Unless if they are not associated with the paradoxical embolism. Uh, Larger defects with the evidence of RV volume overload, echo and closure is usually indicated to prevent the long-term complication such as arrhythmia, reduced exercise tolerance, a hemodynamic significant tricuspid regurg, right to left shunt, congestive cardiac failure, pulmonary vein vascular disease, may develop even up to 5 to 10% of affected, mainly the female individuals. The majority of secondum ASD can be closed with the percutaneous catheter technique. Uh, when this is not feasible or not appropriate, surgical closure is recommended. As we mentioned at the beginning of our lecture, it should go gradually. If it's possible with the percutaneous, no, then minimal invasive even, no, then surgical. The sinus venosus, coronary sinus, and premium defect are not amenable to device closure. ASD with the large septal aneurysm or multifenestrated ASD atrial septum requires careful evaluation by consultation to the interventional cardiologist. So this is for the ESD. Recommendation for surgical VSD closure, class 1 surgeon with the training and expertise in congenital should perform the VSD closure operation. This is level C. Closure of VSD is indicated with if there is a QPQS ratio of 2 or more and clinical evidence of LV volume overload. This is level B evidence. Third, closure of VSD is indicated when patient has history of invective endocarditis. This is level C. Class 2A, first one is closure of VSD reasonable when there is left to right shunting is present with QPQS greater than 1.5 with pulmonary artery pressure less than the 2/3 of the systemic pressure and the PVR less than 2/3 of the systemic vascular resistance. This is level B evidence. Second is closure of VSD is reasonable. The net left to right shunting is present at QPQS greater than 1.5 in presence of LV systolic or diastolic failure. This is level B evidence. Class 3, we have only the if VSD closure is not recommended in patients with the severe irreversible pulmonary artery hypertension. This is level B evidence. So, having said that, the recommendation for the interventional catheterization for VSD, class 2P, device closure of muscular VSD may be considered, especially if the VSD is remote from the tricuspid valve and the aorta, if the VSD is associated with the severe left-sided heart chamber enlargement, or if there is a pulmonary PAH. This is level C. So the indication for the catheter device closure for VSD, if there is residual defect after prior attempt of surgical closure or restrictive VSD with a significant left to right shunt, trauma or iatrogenic artifacts after surgical replacement for the aortic valve. Along with those, the adult population include the history of bacterial endocarditis or hemodynamically significant left to right shunt, which calculated by the QPQRS greater than 1.5 ratio to 1, or as we mentioned in the criteria of evidence. So next, the recommendations for interventional and surgical treatment of coarctation of aorta in adults. Class 1 criteria will be intervention for coarctation is recommended in the following circumstances, one of two, or I mean two of those. Peak to peak coarctation gradient greater than or equal to 20 millimercury. This is level C. Peak to peak coarctation gradient less than 20 millimercury in the presence of anatomic imaging evidence of significant coarctation with radiological evidence of significant collateral flow. This is level C evidence. Secondly, the choice of percutaneous catheter intervention versus surgical of native discrete to coarctation patient. It will be determined by consultation with the team of adult congenital cardiologists, interventionists, and surgeons. In adult congenital heart disease center. This is level C. And third, percutaneous catheter intervention is indicated for recurrent or discrete coarctation and peak-to-peak gradient at least 20. This is level B. Number 4 is surgeons with the training and expertise in congenital heart disease should perform operations for previously repaired coarctation and with the following indication, which are long coarctation segment, this is level B, or concomitant hypoplasia of aortic arch. This is level B also. Class 2B, stent replacement for long segment coarctation may be considered, but the usefulness is not well established, and long-term efficacy and safety are unknown. This is level C. So the appropriate type of treatment for native coarctation of aorta in adult remains somehow controversial. For women, or that will be for childbearing repair, the concern will be the tissue integrity for the coarctation region, particularly during pregnancy. For recurrent patient, the balloon or stent, in the absence of confounding features like aneurysm, so the aneurysm formation, significant coarctation affects the adjuvant arch arterial branches, the adjoining arch arterial branches. So in the majority of circumstances, discrete recoarctation is managed with balloon dilatation or with or without stent placement, but still considered the less suitable for long segment or tortuous forms of coarctation. In many adult congenital center, the surgery reserved for patients who are unstable for percutaneous treatment. Rebound hypertension can occur early after repair and may be prevented or blunted by preoperative administration of beta blocker only. And post-operatively, as we mentioned, it will be go along without any antihypertensive medication. Morbidity in adults with post-operative bleeding, pleural effusion, lung contusion, recurrent laryngeal nerve palsy, or phrenic nerve injury with hemidiaphragmatic paresis or paralysis. Paraplegia secondary to spinal cord ischemia is rare, but more common with poor collateral circulation. Also, arm claudication and subclavian steal syndrome is rare along with these patients, particularly may occur after the subclavian flap technique. For the right ventricular outflow tract reconstruction recommendation, the surgical therapy is recommended for patients with the severe pulmonary stenosis and then associated with hypoplastic pulmonary annulus, severe pulmonary regurgitation, subvalvular pulmonary stenosis, or subvalvular pulmonary stenosis. Surgery is also preferred for the most dysplastic pulmonary valves and when there is association with the TR or need of surgical maze procedure. This is level C, and the surgeon with the training and expertise in congenital heart disease should perform the operation with the RVOT and pulmonary valve. This is level B. So only those two for the RVOT recommendation. The recommendations for the Ebstein's anomalies, class 1 first included many subclasses. Surgeons with the training and expertise in congenital heart disease should perform the tricuspid repair or replacement of the non-committal closure of an ASD when present for patients with Ebstein anomalies with the following indication, which are the symptoms of deteriorating exercise capacity. This is level B. Cyanosis, that SpO2 should be 90%. This is level B. Paradoxical embolism, level B also. Progressive cardiomegaly on chest X-ray. This is level B evidence. And last but not the least is progressive RV dilatation or reduction of RV systolic function. This is level B as well. So second, surgeon with the training and expertise in congenital heart disease should perform the concomitant arrhythmia surgery in patient with Ebstein anomalies and following indication, which are two. The first, the appearance or progression of atrial or ventricular arrhythmia, not amenable by percutaneous treatment. This is level B, and ventricular pre-excitation not successfully treated with EP laboratory. This is level B. The TBR rarely successful, but concomitant MAID procedure may be performed for intermittent or chronic atrial fibrillation or flutter. Third, the surgical repair or replacement of the tricuspid valve is recommended in adult with Ebstein anomalies with the following indication. First, or A, symptoms, deteriorating exercise capacity, or NIHA class 3 or 4. This is level B. Severe TR after repair with the progressive RV dilatation, reduction of RV systolic function, or appearance or progression of atrial and ventricular arrhythmia. This is level B also. Biprothetic tricuspid valve dysfunction with significant mixed regurgitation and cyanosis, level B evidence. Predominant biprothetic valve cyanosis, which with the mean gradient of 12 to 15. This is level B as well. Operation can be considered earlier with a lesser degree of biprothetic cyanosis with symptoms or decreased exercise tolerance. This is also level B. I don't know why. Most of them are level B. Anyhow, the primary operation generally consists of closure of any interatrial communications. The antiarrhythmial procedures such as surgical division of accessory conduction pathway, ablation or cryoablation of AV node, pre-entry tachycardia, maze procedure, tricuspid valve surgery. When the repair is feasible or the repair is result in non-satisfactory, the right reduction arterioplasty is often performed as an alternative. So next is the recommendations for the surgery for adults with the prior Fontan repair or Fontan revision. Class 1 criteria, first, a surgeon with the training and expertise in congenital heart disease should perform the operation on patient with the Fontan revision repair for single ventricle physiology. This is level C. Reoperation after Fontan is indicated for an unintended residual ASD that result in right to left shunt with symptoms or cyanosis not amenable with the transcatheter closure. This is level C. Hemodynamically significant residual systemic artery to pulmonary artery shunt, or residual from surgical shunts, residual from ventricle to pulmonary artery connection, not amenable with transcatheter closure. This is level C also. Moderate to severe systemic AV valve regurgitation, level C. Significant or greater than 30 millimeter mercury peak to peak, subaortic with the subaortic obstruction. This is level C. Fontan pathway obstruction, level C. Development of venous collateral channels or pulmonary arteriovenous malformation, not amenable to transcatheter management, level C. Pulmonary obstruction, level C. Rhythm abnormalities such as complete AV block or sick sinus syndrome that require epicardial pacemaker insertion. This is level C as well. Last, from the first criteria is the creation or the closure of fenestration not amenable to transcatheter intervention, also level C. Class 2A for Fontan revision patients, reoperation for Fontan conversion, i.e. revision of arteriopulmonary connection to an intracardiac lateral tunnel or intra-atrial conduit for extracardiac conduit, can be useful for recurrent atrial fibrillation or flutter without hemodynamically significant anatomy abnormalities. This is a concomitant with the maze procedure should also be performed. This is level C. Class 2B, heart transplantation may be beneficial to severe SV dysfunction or protein losing enteropathy. This is level C. So in conclusion, the reoperation include valve repair or replacement, systemic AV valve, regurgitation, resection, subaortic obstruction, closure of unintended residual of shunts from revision, or Fontan conversion for atrial tachyarrhythmia with or without anatomical abnormalities. The clinically significant persistent venous collateral channels or systemic aortopulmonary collaterals are usually treated with the transcatheter occlusion first. Atrial tachycardia can be treated with the catheter ablation versus Fontan conversion with the maze procedure. Complete AV block or sick sinus syndrome commonly requires permanent pacing, usually epicardial. PLE or protein losing enteropathy, not amenable to medical or catheter therapy, may be treated with the creation of an ASD fenestration or Fontan conversion. The Fontan division carries an operative mortality rate reach up 5 to 25% in reoperated series. The PLE often requires heart transplantation. Thank you.
Well, again, thank you, Amjad. I'm worried a little bit about those slides because they, if you just show the last two slides, maybe one of them. Okay, here. You can see so much crowded, huh?
Yeah.
Please do not use, do not use this kind of slides in your presentation, especially when in front of your board. Huh? Anyway, Guru, do you have any comments or any advice for the guys about this these guidelines?
Fareed, thanks for asking, and well done again for the presentation. So obviously it's a very comprehensive set of guidelines, but all of you will notice that the evidence level for much of this is really poor. But there has been increasing bits of evidence since these guidelines have been published. So this is the 2008 guidelines. And last year, sorry, not last year, the end of the year before, so the end of 2018, so November of 2018, there was actually a new set of guidelines published from the American Heart Association. And the ESC is also just in the final throes of creating their guidelines. And what's much nicer than this original set of guidelines actually is that they've also now incorporated hemodynamic measures and also functional measures. So, so basically it's class A, B, C, in addition to the anatomic diagnosis. So then the indication for surgery and the indication for interventional cath then becomes incorporated with the sort of a hemodynamic assessment, as well as a functional, as well as an anatomic assessment. So it has improved, and there is a little bit more evidence to guide intervention, but still compared to most general adult cardiology conditions, it's still, you know, not quite there, not as good yet.
Thank you, Guru. I have a question for you, Amjad. You keep mentioning the difference between atrial septal defect, the secundum type, and the other types, especially the primum. Can you tell me what ECG finding that will give you a hint that this patient have atrial septal defect primum type?
ECG findings for ASD primum?
To differentiate, yeah, to differentiate the ASD primum. Okay, anybody can help him? Murtada?
This axis deviation.
Exactly, Hussein. This is Hussein, right?
Yes.
Yeah.
Hussein have answered as left axis deviation.
Yes.
Okay, so another question for the senior. He mentioned something about closure of the VSD with the device if the patient have pulmonary hypertension. So I'm going to give you this example. A patient with moderate size VSD, severe pulmonary hypertension, let's say 8 Wood units, with right to left shunt. Hussein, would you close this VSD?
I will repeat the cath and see the reversibility of the shunt and how much can I decrease the pulmonary.
So it came down with nitric oxide down, the resistance came down, let's say, to 6, with still having right to left shunt though.
In this case, if we close the defective patient will develop right heart side failure, and he may not tolerate this closure.
And most likely will end up dying because of your procedure. The same applies for ASDs and anything else. If you have severe pulmonary hypertension, if the patient have reversibility, you would give the patient medication for some time, maybe 6 months to 1 year. If they have very good response, then you may have a chance at closure. But even at closure, you may want to choose a technical trick that will help the patient to shunt right to left, but not left to right. Do you know what's that trick, Murtada?
You mean like atrial fenestration?
So it's a fenestration in the patch, but it's made technically as a valve kind of.
Yeah, batch.
Yeah.
You
So
will
you use two.
one,
Go ahead, Hussein.
one direction batch, so it can allow it's work like BFO.
Okay,
Yeah.
so it allows shunting to one
That's
direction.
Mhm.
Okay. All right. Well, I think those are the important points that all the resident level, junior level, and senior level should be attentive to when you think about adult congenital. And again, yes, please.
It's mentioned here in the guideline, we can close traumatic VSD with device. And
Let's say the patient have traumatic VSD and then he present after 6 months or so. Most likely this part of the VSD will be having very good circumscribed edges. And yes, you can, if you can fit a device there. With the current imaging technique, you can find out the shape of that defect and you can decide if it's doable or not.
But in case of a fresh, still we can do it because it's will in the size with time, right?
Well, it has been reported, yes. It's with the traumatic part especially, it's the muscle still very good muscle, but the potential of failure is high. So if there is an indication for acute intervention, the patient is not doing very well, intubated, getting worse with pulmonary edema and so on and so forth, then yes, you would have to get him to surgery. Attempt of cath, if it's reasonable size, you may attempt that, especially with some experts around you, cardiology, interventional cardiology.
Mm-hmm.
Guru, do you have a comment on that?
Yeah, I've closed a few of those myself in previous days gone by. And trauma, of course, is both blunt trauma and also sharp trauma. You know, some of them are definitely amenable to transcatheter closure, and there's muscular VSD devices available, of course, to help with that. And also, there's some companies that will actually create a device that's shaped to the morphology of the VSD. So many of them are not, you know, clear round defects or oval defects or anything like that. So some of the device companies, if you send them a 3D picture, like 3D echo or 3D TEE picture, they will actually make the device for you to be suitable. So definitely some of them are suitable for percutaneous closure.
Okay, thank you. Murtada, do you have anything else going on? Go ahead.
No.
Dr. Farid?
Yes.
Can I ask one question regarding the question you said to the Dr. Hussein? You said that if the resistance comes down to 5 Woods, can we close it or not? So what is the cutoff? Is it 4 or 5 or 6? Because it's mentioned in the book that it's 5. And I think one time you said it was 4. But is there a certain number?
Well, we are becoming more and more aggressive with those. At one time we thought any resistance more than 2 is too much. Then we went up to 3, 4, 5. Now even up to 8 we can consider. But you have to do your homework, basically looking at the hemodynamic, looking at reversibility, and giving the patient a chance, if they can tolerate and benefit from medical treatment for some time, to treat the pulmonary hypertension. The worrisome is that you close, some of those patients that you close, they will develop right-sided heart failure. Their right ventricle will not cope with that, and the patient end up dying earlier rather than later. Most of the patients with pulmonary hypertension will end up dying because of their disease or a complication of that. So they found that any patient who have a shunt that relieve that pulmonary hypertension, either in the form of ASD or VSD, they live longer than the patient who do not have that shunt. So if your chances of helping the patient with that pulmonary hypertension has a left to right shunt, and the patient have reversibility, you can probably take a chance at a higher number. Again, you cannot be just rigid about a certain number. Let's say you said 5. What about 4.9? Okay, what about 5.1? And so you have to be looking at all the clinical picture together. Any advice on that group?
Dr. Farid.
Yeah, there are different guidelines, and maybe the confusion arises from that. So the European guidelines, they have a cutoff of 5. And I think the new guidelines, I'll have to refresh my memory, I think are about 4.5 for Wood units. But as Dr. Farid says, that's not the absolute cutoff. So even if your PVR is a little bit above 5, but the pulmonary artery pressures are less than 2/3 systemic, or the pulmonary vascular resistance and the systemic vascular resistance ratio, is less, and I have to refresh my mind about this, but I think a ratio of less than 1.3, then those patients can undergo intention to treat sort of with pulmonary vasodilators, 1, 2, 3 pulmonary vasodilators, and restudied to see if they now meet criteria for intervention. And some of them do get better. And interestingly, some of the sinus venosus ASD patients are often overread in terms of their pulmonary vascular resistance, and many of them actually respond reasonably nicely. And there's, interestingly enough, there's also a different approach from China. Some Chinese centers with patients that have sort of just borderline high pulmonary vascular resistance, and that's to ban the PAs and allow sort of gradual remodeling whilst you give them anti-pulmonary hypertensive medications. And some of them are reported also then to come back and be suitable for closure. But as Dr. Farid said, not complete closure, but to have a VSD that was responsive to right to left shunting, but not left to right, if you know what I mean. So yeah, that's it.
Dr. Gru?
Sure. Yes. Hi.
Yes, this is Dr. Murtada. I'm an R5 cardiac surgeon. I want to ask you about this, about the use of pulmonary vasodilators and those patients, because what I know that pulmonary hypertension due to left heart disease, like in ASDs, it's a class 3 recommendation to use pulmonary vasodilators for those patients, because some studies showed decreased survival or worse outcome if we use vasodilators for those patients. But I don't know if these studies tackle patients with post-operative persistent pulmonary hypertension, or they also included patients with pre-operative pulmonary hypertension. So I don't know, what's your comment about this?
Yeah, so many of the studies, if you look at the large pulmonary hypertension studies, and I've not kept up with the literature very much on just pure pulmonary hypertension, because we send them now very much to the pulmonologists, and we have a sort of a joint management. But I used to run a pulmonary hypertension clinic in England when I was still there, and basically, many of the large trials include a spectrum of congenital heart disease. And the ones that have had post-operative residual pulmonary hypertension are very small in the trials. But those patients really have a much, much worse prognosis than even idiopathic, so-called idiopathic pulmonary hypertension, or Eisenmenger physiology. So those patients really have to be treated very aggressively with pulmonary vasodilator therapy. And some people have gone even as far as creating a AP window between the descending aorta and the pulmonary artery to really rectify that, that situation. But so I agree with you. I think it's a very concerning situation. But unfortunately, there's not much in large trials on that subgroup of patients.
Doctor, when we look at the pathophysiology of this kind of pulmonary hypertension, I remember reading something about the protective nature of the development of precapillary pulmonary hypertension in those patients, because of the continuous right to left shunt and the increase in the venous pulmonary hypertension. The precapillary side constrict in order to decrease the flow from the right side, to decrease the pulmonary edema. And so when we give vasodilators for these patients, they observe that they have more pulmonary edema, because we disturb this protective mechanism. So again, if we have a patient with like the patient you mentioned with a borderline borderline pulmonary vascular resistance on the higher side, like five something, and we gave him a vasodilators to, yeah, I think, do you think it's a good idea to give this patient?
Well, I think you may raise a very important point there, Dr. Matara. It's on a different scale, I suppose. So in the early time, before you have established pulmonary vascular disease in patients with the left or right shunt, if you look histologically, all you have is medial hypertrophy in the small to medium-sized muscular pulmonary artery still, so way out into the lungs. So they just get medial hypertrophy. But even for the ones that have a left to right shunt, eventually you'll get remodeling of the small pulmonary vascular vessels so that you get fibrosis, dilation, intravascular coagulation, and then also complete obliteration of the vascular bed eventually, and that grading is well recognized in pathological series. Now that is as true for Eisenmenger syndrome or lesions resulting from congenital heart disease as it is for de novo kind of pulmonary hypertension from other causes like from rheumatological conditions. So in answer to your question, once the patients get to established pulmonary vascular disease, in other words, they have disease in the small vessels like the idiopathics or the ones due to scleroderma or, those conditions, really you in a similar ballpark in terms of the anatomy. The physiology obviously is a bit different because they can right to left shunt, and that's why many of them still do better than the idiopathics who haven't got the ability to right to left shunt and maintain their cardiac output. But really they do respond to pulmonary vasodilators. And there was a study that spun off, it was called the Breathe 5 study. And they looked at survival after a pulmonary vasodilator therapy in advanced Eisenmenger syndrome. And they did demonstrate some survival benefit in those patients. But the main thing is not so much survival as in improvement of symptoms. So the systemic vasodilation as well as the pulmonary vasodilation really still gives them some improvement in symptoms and a little bit in terms of their functional capacity.
So what I understood from what you just said, that pulmonary vasodilators may be of a benefit if we reach at the stage of anatomical vascular changes.
Exactly right. Exactly
Yeah.
right. Mm. Exactly.
But there is no way to find out if we reach that stage, right? Or maybe we can just rely on the chronicity of the disease. But
well,
is there any objective test or something to tell us if there's anatomical changes or not?
Sure. So if you look at the natural history, and the natural history is very clear. So usually by the time the patient's right to left shunt, the pulmonary vascular bed is very, very much affected. So that's one clue. Second clue is if you look at the heart size and you look at the X-ray. So, a patient with left or right shunting, they've got pulmonary congestion, increased vascularity, the heart is big. So what happens, all of that shrinks down, becomes more normal, and then the patient becomes blue. Almost certainly you've got pulmonary vascular changes. But if you then wanted to really confirm that, CT scan will help you. You can see pruning, you can see calcification, you can see decrease in the pulmonary vascular bed itself. The branching and so on really decreases. And then if you did a 3D reconstruction of the pulmonary vascular bed as well, you can see maybe 50–60% of the pulmonary vascular bed may be gone, and then of course, you can do lung biopsy like they did in the olden days, but that carries quite a bit of risk to it. But occasionally we still do lung biopsy if we're uncertain of exactly the question that you're asking, how far down that line has the patient gone? And there are still some situations like that, but most of the time I would say it's not so difficult to know.
Thank you very much, Victor.
Sure.